Question number 6 is identify the green colored nucleus and its functional component. I hope you know the green colored nucleus is visible to you. If not, I'm like making it more clear. Zoomed it out. Now think about this green colored nucleus. Which nucleus is this? The green colored nucleus. I hope you understood the diagram. This diagram you're seeing is okay. Let me zoom in. This diagram you're seeing is of the brain stem. That's the title section. So here you're seeing is this portion here is the midbrain. This is the pons, and this is the medulla oblongata. And on the dorsal side, these are the corpora quadrigemina, the superior and inferior collicles on the dorsal side of the midbrain. And the cavity of the midbrain you are seeing is the central cavity aqueduct, right? Aqueduct of Sylvius. Then on the dorsal side of the pons and the upper portion of this medulla, you find that this is a cavity in which actually is dilated and it's tent-shaped. It is having a tent-shaped roof. So that's the fourth ventricle. And fourth ventricle communicates to the subarachnoid space through a median foramen of Vijayndi, and two lateral foramen, those are foramen of Lishka. Anyways, so my purpose is to focus on the green colored nucleus here. This nucleus, right? We're talking about this. So can you see the fibers emerging out from this green colored nucleus? They're moving upwards medially and then dorsally. Dorsally, they are winding another nucleus. So this winding upon this nucleus and then forming a curved thing and then emerging out laterally at the pontomedullary junction here. This is the exit of fibers. So what you think is this nucleus? Remember, now I think I should put up the answers for those who have yet they've guessed it now. So the answer here, of course, is motor nucleus of the facial nerve. So you know that the different motor nuclei, the three functional columns divided in the motor group. So medial most is the general somatic efferent fibers. That includes the third, fourth, sixth, and the 12th nerve nuclei. Then later to that is like the special visceral efferent component. And even later to that is the general visceral efferent. That's for the innervation of the smooth muscles. That's autonomic efferent, parasympathetic efferent. But right here we're talking is about the second functional column from the medial, for the median sulcus. So this one is special visceral efferent functional component. And this nucleus will innervate the muscles derived from the branchial arches. This motor nucleus of facial nerve will innervate the muscles derived from the second branchial arches. The fibers you're seeing is winding, and when it winds behind, they're on this dorsal aspect, or you can see on the floor of this fourth ventricle. This is the fourth ventricle. So in its floor, you find two bulgings in the medially, and those are called the facial colliculus. This facial colliculus is because the fibers of facial nerve, they wind around this deeply, seated abducent nerve nucleus. This is facial nerve nucleus, no doubts. Facial nerve, cranial nerve nucleus. Which one is a motor nucleus? And the functional component is special visceral efferent, which you call as branchial efferent. While this one, which is crossing it, is the sixth nerve, abducent cranial nerve nucleus. Okay, because abducent will be a medially placed nucleus because it's innervating the muscles derived from occipital somites, somatomeres. So, the extraocular muscles. LR6, lateral rectus. So this nucleus, facial nerve nucleus, will be a little later to the abducent nerve nucleus, but fibers will wind medially, and that's how it crosses. I hope you've understood this. Okay. Question number 7. Muscle producing the movement of the right eye. See the image properly and think about the movement being the movement, of course, in the right eye, and which is the muscle that producing this movement of the right eye. By now you must have guessed your answers, so let's move to the answer here. So before telling me the answer, you should know, and the purpose of this lecture is to explain you these little bit concepts. So when you are generally the students confuse with when you're talking about gaze. When you're talking about gaze means when you are looking at a distant object. So you have this binocular conjugate movements of the eyes. If you're looking far off, you're moving towards the right side, both your eyes will move parallelly. If you're moving to the left side, upwards, outwards, whatever your direction you'll move, both your eyes will move parallelly. Like that's called conjugate movements of the eyes. And binocular vision, because both the eyes will have like an overlapping image. So that's what I'm telling. This is the way we're talking is about the gaze. But testing of these muscles is a different thing. So don't confuse with the testing of muscles. I'll tell you because many people get confused with the action of inferior oblique and superior oblique. So here I am telling you all the movements according to the far of vision. We're looking at a distance, the gaze. So with that concept, now think here the upper image which is showing the both right and left eyes, and in between of course will be the nose. Here it's the nose, right? So now look here. Now you have like 7 extraocular muscles, right? And out of the 7, one is not related to the eyeball, but it's related to the upper eyelid, and that is LPS, levator palpebrae superioris. Levator palpebrae superioris has both skeleton and smooth muscle component. The skeletal component was innervated by oculomotor nerve. The smooth muscle is called the Muller's muscle, innervated by sympathetic fibers. Right now, look at the 6 extraocular muscles. You have 2 medial, medial and lateral rectus. Medial rectus will cause adduction, that is like nasal deviation of the eyes towards this nose. So adduction of the eyes is by medial rectus. Then you have the abduction, means lateral deviation of the eyeballs, right? Temporal side, that is by lateral rectus. Clear? Now remains are the superior and inferior rectus and superior and inferior oblique. Keep focusing on the image, the upper image. Then, just if you have this image fixed in your mind, you'll never get confused with this. Recti are placed medially and obliques are placed laterally. Just focus on the image, not on the insertion thing, the origin thing, right? Only upon the image, just to learn the different direction movements of these muscles. So when you fix this diagram, remember the recti are placed medial towards the nasal sides, up superior rectus, inferior rectus. Right? Similarly, now talking about the obliques. Obliques are placed laterally. But contrary to the names, because of their insertion thing, which I'll discuss in ophthalmology lectures, right now, just remember that against to the name, opposite to the names, inferior oblique will be placed upwards. It's pulling the eyeballs upwards from the lateral ends, like superolateral gaze. And superior oblique is pulling it downwards, infralateral gaze. So recti will pull up the eyeballs like this, upwards and medially, both these. And inferior recti will pull it downwards and medially. Inferior oblique upwards and laterally. Superior oblique downwards and laterally. That's how it's given here. So with that, now you look upon images below, the 6 images. They've tried to show by the movements of the eyes in different gaze. If you're looking on the right side, upwards gaze. So upwards and to the right, both the eyes, binocular conjugate movements. So in the right eye, this action you're seeing is being performed by inferior oblique, right? I told you about inferior oblique, upwards and outward gaze. And in this left eye, the same movement, conjugate movement. Now this will be by superior rectus. Here, superior rectus. Okay. Now similarly on the left supralateral gaze on the left side. So it will be inferior oblique in the left eye and superior rectus on the right eye. Now simply looking towards the right and towards the left, like looking to the right, so right eye will be moving it laterally, lateral rectus, and at the same time the left eye will look towards the medial side, medial towards the left. So there will be medial rectus in the left eye. Now looking towards the left side, so left eye will be moved because abducted outside, that's why lateral rectus, and medial rectus will be moved towards the left side on the right eye. Now think about downwards and lateral gaze from the right side, on the right side. So right side downwards and laterally, it is by superior oblique in the right eye, but in the left eye it will be by inferior rectus. Here you've seen it. Inferior rectus is this and superior oblique is this. Similarly, now looking on the left side downwards and laterally, so the left eye will obviously move by superior oblique, and from the right side it was now medially placed. This downwards and medially is by inferior rectus. Understood? So focus on the image in question. I hope you guessed the answers by now. We were talking about the muscle causing the movement of the right eye. So have you guessed the answer? Okay. So here's the answer in the image left out. Muscle producing the movement of the right eye is this one, inferior rectus. Okay. It's downwards and medially towards the left side. Question number 8 is identify the histology slide, its identifying features. Think about the epithelium, the folds in the epithelium. Then think about the deeper tissues. If you find any muscles, if you find any glands, and if you find, the foldings of this epidermis, thickening of the epidermis, what can you guess? What the slide should be? So, time up. The answer here is it's slide of a tongue. So, the identifying features here, one thing is, I have already been telling you, just first of all, when you see a periphery of an histological section, start moving from periphery to center. One thing you're seeing is that the epithelium is a stratified epithelium because you see not a single layer, it's having much of cellularities, so this you are seeing is the epithelium. And this epithelium, I previously told you that if you find such papillary projections from an epithelium downwards, that confirms that this is a stratified squamous epithelium. And to be if you zoom it or if you see in a better microscope, you will find that nuclei, the nuclearity is visible in the basal layers, like basal layer, stratum spinosum, it will be visible, but granulosum, lucidum, corneum, the nuclei are not easily visible because they have protein deposited intracellular. Keratohyalin, ellitine, keratin on these layers. So nuclei will be present, visible in the lower layers. That's about the stratified squamous epithelium. Now, because if it's a tongue, so that has like a lot of papillae over to the tongue. Like filiform is the most common small projections, and those are not associated with tastes. Then you have fungiform, foliate, circumvallate type of papillae. These circumvallate papillae are present in the anterior two-third, just anterior to the sulcus terminalis. So these are one important part about this circumvallate papillae, right? So you know that the taste sensations from the anterior two-third are being carried by chora tympani, and taste sensations from the posterior one-third of the tongue are being carried by glossopharyngeal, that's posterior to the crista terminalis. But important point is that these circumvallate papillae, although present anterior to the sulcus terminalis, but the taste sensations from circumvallate papillae will be taken by glossopharyngeal. Okay. So now look here. Actually, what is this? This is actually a you can say a coronal or a sagittal section, not a transverse section. If you take a transverse section here, let's say it's like a transverse section here. So when you, what you will find that this is like this thing. This is a pillar, and surrounding to this pillar is a cavity, a well-shaped cavity. So this is a pillar. This is a pillar here, and surrounding to that is a cavity, and that is circumferentially along to this pillar. A pillar, then a well-like cavity, that is called circumvallate papillae. On the surface it will be like this. This is the papillae, and then here it is the rest of the structure of the tongue. So you find is a well-shaped ridge deep surrounding to this papillae, and that's called circumvallate papillae. Now if you take a transverse section here, like that is what they have shown here, so it will appear like this, right? So onto this, this surface, onto the margins here, you find is these taste buds. So taste buds are present on the margins of this well-shaped surrounding ridge around to this papillae. So there you finding, can you see, appreciate these taste buds? I think they are visible. You can see these are the taste buds. Here also, here also, these are the taste buds. Here also, these are the taste buds. So taste buds surround the cleft surrounding to this papilla. This is helping you identify, right? But it's not necessary in every section of the tongue you'll find this. You might find the papillary projections also sometimes. Cornified, these are cornified papillary projections. And you might also find blood vessels, and some projections might be cut obliquely, or some, like, these clefts, this sulci. There's a fold also, folds on the lateral side of the tongue. So you might find some sections in this oblique cut sections, transverse cut sections, some sort of, and even the blood capillaries will be present there. You find blood capillaries here. Here also somewhere blood capillaries will be present, right? And can you see these glands here? These are richly stained, right? They're having a good stain. So whenever a gland, the acini, are taking good stain, violet stain, that means there is more of proteinaceous content, more protein synthesizing apparatus within these acini, and that means these are serous acini. So serous acini take good stain, but mucous acini do not take good stain because they are mucin. Mucin is a neutral substance. So therefore, these glands you're seeing are the serous salivary glands, lingual glands present in the tongue. And one more thing you're seeing down below is these muscle fibers, right? So these muscle fibers make you understand that is the tongue, the intrinsic muscles of the tongue. Okay, and you find is the scattered lymphocytes. You find in all the way there is scattered lymphocytes as well. But these are scattered, in most of the portion of the tongue, but in the posterior 1/3 of the tongue. These are actually aggregates of lymphocytes. Clump, nodules sort of aggregates, clumps of lymphocytes, and form nodules in the posterior 1/3 of the tongue, and those are called the lingual tonsils. Okay, histology you need to practice regularly. Keep watching slides, histological slides. That's how you can learn. Now, question number 9 is identify the clinical condition, the image here, and explain the reason. What is this clinical condition? They have mentioned that there is a discomfort behind the left knee joint. What is that view? That's a popliteal fossa of the left knee joint. And you're seeing is a centralized swelling. It's not neither medial or lateral, it's rather in the center of the popliteal fossa. And the mention is discomfort. What this could be? So now let me tell you about this, that this is called Baker's cyst. Now Baker's cyst is what cyst? It actually is also called popliteal cyst. Now in certain conditions, when there is because there is cartilage, articular cartilage of the condyle or the tibia, they are devoid of perichondrium. So certain conditions like arthritis or any condition when there is tearing of the cartilage, there is, due to inflammation, there is more overproduction of the synovial fluids. And this synovial membrane, actually, if you remember that posteriorly the capsule of the knee joint has a gap, and that gap is for the passage of the tendon of popliteus. The popliteus has an intra-articular origin from the lateral condyle of the femur. It grooves the femur on the lateral side and then emerges out of this opening in the capsule of the knee joint behind. And that opening, it will easily get torn out because it's this muscle, popliteus, which is a key muscle of the knee joint. It unlocks the knee joint by laterally rotating femur over the tibia. Will this happen regularly? There will be chances of rubbing of this capsule. So the margins of the opening of the capsule from where this tendon comes out, that margins are thickened and the strength is reinforced by fibers from the short lateral collateral ligament. So those fibers from the short lateral collateral ligament, which arc above to the popliteus and strengthen this opening, is called arcuate popliteal ligament. Now, through this opening from where this popliteus tendon is coming out, synovial bursa, synovial membrane also will protrude out because there is enough of fluid being deposited. So that, that bursa, that synovial membrane actually protrudes out, and that forms a cystic swelling on the back of the knee in the popliteal fossa. That we call as popliteal cyst or Baker's cyst, right? So this will of course be a cause of the pain, especially like when you are standing erect, you are forcing upon the two bones, femur and tibia. So there is like compression of the membrane fluid, so that will pushed out more behind in an erect posture or the locked knee. I hope you understood this. Identify the green colored muscle and its action. So you are seeing the muscles of the back of leg. It's a superficial large muscle of the back of leg with its two heads, right? So this muscle is semimembranosus. The semimembranosus takes origin from femur, means above the knee joint, with its two heads from the medial and lateral supracondylar ridges of femur. Both the two heads then descend down in the back, that's the muscles of calf. It covers soleus from behind, and together with soleus it forms a common tendon that's called tendocalcaneus or tendoachilles, which is inserted on the posterior surface of calcaneum. But remember, in between these two muscles there is another muscle, which is a vestigial muscle, and that is arising from above to the lateral head of gastrocnemius, that is plantaris. Plantaris will have an oblique course in the back of leg. So along with the lateral head of gastrocnemius, plantaris descends down between gastrocnemius and soleus. Remember that plantaris is having an oblique course in the back of leg. When I'm saying it's oblique course, you should think about its insertion, because on the calcaneum posteriorly there are two impressions, a lateral impression and a slight medial impression. So plantaris will be inserted on the medial impression because of its oblique course, while tendoachilles on the lateral impression. Together, the three muscles, don't mix up plantaris in between. When we talk about triceps surae does not include plantaris. Triceps surae means the two head of gastrocnemius plus soleus. That's triceps surae. Now, because in the image you have seen the animation here, the green color one, of course, is the medial head. Medial head and lateral head, if you see, the medial head of gastrocnemius is more bulkier, and a medial head at its upper end, right? It was coming from this medial supracondylar ridge. So there it has a bursa intervening, arise from where it arises, and that bursa is called Brody's bursa. So remember, medial head is related with Brody's bursa, and the lateral gastrocnemius you find in occasionally a sesamoid bone, and that's called fabula. So remember, lateral head is related to fabula, medial head is related to Brody's bursa. Then that's identification, and then about its action. So remember, obviously these muscles, both gastrocnemius and soleus, they help for, because there's a muscle at the back of leg, therefore plantar flexion of the ankle joint. So when you are walking on heels or high heels, your calf muscles bulge out more. That is also a sort of secondary sexual character. But this muscle is rising from above the knee joint. That's from femur. So this will also have an action on the knee joint. So it will also be a flexor of the knee joint as well as flexor of this ankle, plantar flexion. Now talking about running, when you start running, like you have seen the sprinters in a relay race. So they actually make a position with the flexed knees, and with one knee they have the front leg which you place, they have a flexed hip and flexed knee, while the leg that is put behind has a plantar flexion, so that they're ready for running. The moment you start running, it's the soleus that takes the first gear. The first gear is when you take up the speed, you build up the speed, that is through soleus. When you've already taken up the momentum of running, now you increase your speed further. That's like top gears, second, third, fourth gears. So the top gears are being maintained by gastrocnemius. So I hope you understood about these muscles. I've made you revise about all the relevant things here in the back of leg. And don't forget that soleus is also called the peripheral heart. It has venous sinusoids in its substance and the perforating veins. Because of that, unidirectional anti-gravity flow of blood because of that valvular pattern. So soleus is also called a peripheral heart. So that was all for today.